Before we move on, I want to quickly share something that could really help you. You can now join our online NCLEX crash course, specially designed to help you pass the NCLEX on your very first try. This program has already helped over 1 lakh nursing students clear the exam successfully. And now, it's your turn. And here's the exciting part. We're giving a limited time 70% discount on the course fee. But remember, this offer is only for a short period, and seats are filling up fast, so don't wait too long. To enroll, just download our mobile app. You'll find the link in the description box below, or you can scan the QR code you see on your screen. This NCLEX crash course is truly a one-stop solution. It's a proven shortcut that helps you study smart and pass with confidence. So don't wait. Enroll now and stay ahead of thousands of other students in the race to pass the NCLEX. And yes, if you'd like some free PDF notes for NCLEX questions and a free NCLEX ebook, just download the mobile app. You'll get instant access to all those materials right away. All right, let's get back to learning. Here comes the next question. Hello, and welcome back to another dynamic and high-yield session with Stan Coast Nursing Coaching. Each day, we explore 2 to 3 key NCLEX topics that build your clinical confidence and help you master the art of nursing care. And today's topic focuses on the body's vital oxygen carriers, the red blood cells. Our focus today is nursing care of clients with red blood cell disorders, a cornerstone of hematologic nursing. We'll explore major conditions such as anemia, polycythemia, and sickle cell disease, breaking down how changes in red blood cell count, shape, or function affect tissue oxygenation and overall health. Throughout this session, we'll connect pathophysiology to nursing care, explaining how to recognize classic signs like pallor, fatigue, tachycardia, and dyspnea, and how to apply targeted interventions such as oxygen therapy, iron or vitamin supplementation, hydration, and transfusion safety. You'll also learn how to differentiate between types of anemia, whether it's iron-deficiency, pernicious, or aplastic, and understand the rationale behind each management strategy. By the end of this class, you'll be able to confidently assess hematologic findings, prevent complications like sickle cell crisis or transfusion reactions, and deliver evidence-based nursing care that supports oxygen balance and client recovery. So, get ready to learn, apply, and excel. Because here at Stan Coast Nursing Coaching, every topic is not just a lesson, it's a leap toward your NCLEX and NORCET success. Let's begin with today's major concept, red blood cell disorders. See this for a few seconds. If you're aiming to pass on your very next attempt, the ultimate NCLEX crash course is your shortcut, already trusted by more than 100,000 nursing students who cleared their exam successfully. What makes it different? It's an all-in-one package, designed to cover every part of your NCLEX prep. Interactive live classes and easy to watch. Recorded lectures, 5,000 exam-style practice questions, 30 complete practice tests, eBooks, and a PDF notes for revision, a ready-to-use student planner, NGN questions broken down in detail. During comprehensive lecture, this isn't just another review, it's everything you need in one. Please scan the QR code right now, or use the link in the description to enroll instantly and grab free content, including PDF notes, practice tests, and NCLEX quizzes. You'll also get. Moving forward into another high-yield clinical reasoning question, imagine this scenario. A 71-year-old client undergoes a routine complete blood count that reveals a low red blood cell count and reduced hemoglobin levels. The client reports fatigue, weakness, and a pale appearance that has gradually worsened over several weeks. The nurse's task is to interpret these findings and determine which condition is the most likely underlying cause of the anemia. The available options are as follows. Option A suggests mitral valve insufficiency. Option B indicates arteriosclerotic heart disease. Option C points to peptic ulcer disease. And Option D lists benign prostatic hypertrophy. The correct answer is Option C, peptic ulcer disease. When evaluating an older adult with unexplained anemia, the nurse must connect laboratory findings with possible causes of chronic blood loss. Peptic ulcer disease remains one of the leading sources of occult gastrointestinal bleeding in the elderly, especially among those taking non-steroidal anti-inflammatory drugs, or corticosteroids, for chronic conditions such as arthritis or cardiac disease. Even slow daily erosion of gastric or duodenal blood vessels can result in persistent blood loss that eventually leads to iron-deficiency anemia. This explains why the client experiences fatigue, pallor, and weakness, often before any visible signs such as melena or hematemesis appear. In peptic ulcer disease, the mechanism revolves around mucosal injury caused by Helicobacter pylori infection or prolonged acid exposure. Once a blood vessel is breached, the body loses small but significant amounts of iron daily. Over time, this reduces hemoglobin synthesis and leads to microcytic, hypochromic red blood cells visible on the complete blood count. For this reason, anemia may be the first clinical clue to an otherwise silent ulcer. Hence, a nurse's awareness of the link between chronic gastrointestinal bleeding and anemia is critical for timely recognition and referral. Turning to option A, mitral valve insufficiency can cause symptoms like dyspnea and fatigue due to reduced cardiac output, but it does not directly cause a reduction in red blood cells. The fatigue seen in this case is from poor oxygen circulation, not from anemia. Considering option B, arteriosclerotic heart disease impairs coronary and peripheral circulation, but does not affect red blood cell production unless severe renal ischemia occurs, which is rare in stable disease. Finally, option D, benign prostatic hypertrophy, primarily causes urinary retention and occasional hematuria, but blood loss is minimal and insufficient to cause systemic anemia. Moving forward to an insightful perspective, Stan Coast Clinical Insight. Chronic anemia in elderly individuals should always prompt a search for slow gastrointestinal bleeding. Fatigue in this population is not merely a sign of aging, it is often a subtle warning of hidden blood loss from ulcers or malignancy. Finally, turning to a high-yield exam takeaway, Stan Coast High-Yield NCLEX, Pearl. In clients with unexplained anemia, always test for occult blood in the stool and review medication history for non-steroidal anti-inflammatory drug or aspirin use. The triad of fatigue, pallor, and low red blood cell count should make you think of a hidden bleeding source. Key nursing priorities include notifying the healthcare provider, preparing the client for diagnostic endoscopy, and initiating iron supplementation or transfusion as ordered. Let us now transition into another clinical reasoning question that blends hematology and nursing care planning. After identifying and treating the underlying cause of anemia, the nurse develops a care plan to help the client manage persistent fatigue. The key question here is, which nursing intervention best supports the client's recovery while conserving energy and promoting a gradual return to activity tolerance? Let us review the options carefully. Option A suggests encouraging the client to get at least 8 hours of uninterrupted sleep each night. Option B recommends having the client perform moderate exercise twice daily to rebuild stamina. Option C advises instructing the client to increase intake of simple carbohydrates for quick energy. Finally, Option D focuses on encouraging the client to balance activity with frequent rest periods throughout the day. The correct answer is Option D, encouraging the client to balance activity with frequent rest periods throughout the day. Now, let us understand why this choice is the most appropriate. In clients recovering from anemia, the oxygen carrying capacity of the blood remains reduced for some time, even after the primary cause, such as blood loss or iron deficiency, has been addressed. Because of this temporary limitation, the tissues continue to receive less oxygen than normal, causing ongoing fatigue and weakness. To support recovery, nurses must prioritize energy conservation and graded activity. By encouraging the client to alternate periods of rest with mild activity, oxygen use is optimized without straining the cardiovascular and respiratory systems. This pacing strategy prevents exhaustion, allows the heart rate to stabilize, and promotes gradual improvement in endurance as red blood cell and hemoglobin levels normalize. Although adequate nighttime sleep, as stated in Option A, is beneficial for recovery, it does not teach the client how to manage daily activities effectively or conserve energy throughout the day. Option B, which promotes exercising twice daily, can be counterproductive in the early recovery phase because overexertion may trigger tachycardia, shortness of breath, or even chest discomfort. Option C, suggesting an increased intake of simple carbohydrates, may provide temporary bursts of energy but fails to support long-term stamina or tissue oxygenation since it does not correct the fundamental issue of oxygen deficiency. Therefore, the nursing plan that emphasizes balancing activity with rest remains the safest and most evidence-based approach. Now, shifting toward a professional reflection, Stan Coast. Clinical Insight. Fatigue management in anemia. Recovery is about pacing, not pushing. Encourage clients to conserve energy by performing tasks in a seated position, using assistive devices when needed, and scheduling rest before and after physical exertion. This prevents oxygen debt and supports a sustainable recovery. And building upon that wisdom, Stand-Coast High Yield NCLEX. Pearl, always remember the concept of cluster care and conserve energy. Teach clients to prioritize essential self-care during high-energy times, intersperse tasks with rest periods, and closely monitor for warning signs of overexertion such as tachycardia, dizziness, or breathlessness. This principle is vital in both anemia management and any condition involving limited oxygen delivery. Moving forward in our learning journey, let us analyze another insightful scenario that tests both diagnostic reasoning and understanding of pathophysiology. An 18-year-old college student visits the University Health Center, reporting progressive fatigue, pallor, and difficulty concentrating. The nurse carefully reviews the client's diet, which primarily consists of instant noodles, bread, and coffee, with minimal intake of meat or leafy vegetables. The healthcare provider suspects iron-deficiency anemia. The question asks, which laboratory test result would the nurse expect to be lower than normal if this diagnosis is correct? Here are the available options. Option A suggests an Epstein-Barr virus, EBV, titer. Option B lists the thyroid-stimulating hormone TSH level. Option C presents the fibrinogen level. Option D identifies the hemoglobin HB level. The correct answer here is Option D, hemoglobin HB level. When a client presents with fatigue, pallor, and poor dietary intake, iron-deficiency anemia should immediately come to mind. Iron plays a critical role in forming hemoglobin, the protein in red blood cells responsible for transporting oxygen throughout the body. When iron levels fall, the bone marrow produces smaller, paler red blood cells, known as microcytic and hypochromic cells, that cannot effectively deliver oxygen to tissues. This leads to clinical manifestations such as fatigue, dizziness, shortness of breath, and reduced concentration. A hemoglobin level below 12 grams per deciliter in females or below 14 grams per deciliter in males confirms a diminished oxygen carrying capacity, consistent with iron deficiency. Supporting laboratory findings typically include low hematocrit, low mean corpuscular volume, low ferritin levels, and elevated total iron binding capacity. Ferritin reflects the body's stored iron. When it is depleted, it signals iron deficiency even before hemoglobin levels begin to drop. Clients may also show signs such as brittle nails, koilonychia, inflammation of the tongue, glossitis, and pica, a craving for non-nutritive substances like ice or clay. Transitioning to the incorrect choices, Option A, the Epstein-Barr virus EBV titer, detects antibodies for infectious mononucleosis. Although this viral illness can cause fatigue, it primarily affects white blood cells, not red blood cells, and therefore would not reduce hemoglobin levels. Next, Option B, the thyroid-stimulating hormone TSH test, evaluates thyroid function. While thyroid disorders can contribute to fatigue, they do not directly influence iron or hemoglobin synthesis. Finally, Option C, the fibrinogen level, measures a clotting protein produced by the liver. Abnormal fibrinogen levels are associated with liver disease or disseminated intravascular coagulation (DIC) but have no connection to anemia or oxygen transport. In conclusion, the most accurate and clinically relevant laboratory indicator of iron deficiency anemia is a decreased hemoglobin level. This finding connects the client's dietary habits, physiological mechanisms, and presenting symptoms into a unified diagnostic picture. Transitioning to the Stand-Coast clinical insight. Fatigue in a young adult is often nutritional before it is pathological. Always assess diet patterns and menstrual history in adolescents or college students who complain of tiredness. Detecting iron deficiency early prevents complications like developmental delays, poor academic focus, and tachycardia due to chronic hypoxia. Moving forward with the Stand-Coast High Yield NCLEX Pearl. Remember this golden connection: low iron, low hemoglobin, low oxygen, high fatigue. Always interpret laboratory values in correlation with symptoms and confirm iron deficiency anemia with ferritin and RBC tests for complete accuracy. Let us now dive into an insightful case that highlights the importance of clinical observation in identifying anemia. A 42-year-old office worker visits the clinic complaining of persistent fatigue, cold intolerance, and reduced exercise tolerance. During the nursing assessment, the client mentions, "I feel cold all the time, even when others are comfortable. The nurse must determine which piece of information is most relevant to confirming a diagnosis of anemia. The available options include Option A, the client reports chronic lower back pain. Option B, the client experiences frequent headaches. Option C, the client feels cold most of the time. And Option D, the client had rheumatic fever as a child. After considering these clues, the correct answer is Option C. The client feels cold most of the time. This particular symptom stands out as a physiologically significant indicator of anemia. Feeling persistently cold occurs because a reduction in circulating red blood cells and hemoglobin diminishes oxygen transport to body tissues. As oxygen supply falls, cellular metabolism slows, leading to reduced heat production and overall energy output. The body compensates through vasoconstriction to maintain oxygen flow to vital organs, but this further reduces warmth in peripheral areas, making clients more sensitive to cold temperatures. Expanding on this further, in iron-deficiency anemia, inadequate iron stores impair hemoglobin synthesis, producing microcytic and hypochromic red blood cells that are inefficient at carrying oxygen. This leads to hallmark symptoms such as pallor, fatigue, weakness, dizziness, pica, and cold intolerance. Laboratory investigations often reveal decreased hemoglobin, hematocrit, mean corpuscular volume, MCV, and ferritin, with an elevated total iron binding capacity, TIBC. These findings confirm the underlying iron deficiency and support the diagnosis. Shifting attention to the incorrect options, Option A, chronic lower back pain, is not associated with anemia and offers no diagnostic relevance. Pain alone cannot indicate reduced oxygen carrying capacity. Option B, frequent headaches, may occur in some anemic clients due to reduced cerebral oxygenation, but is a non-specific symptom that could result from other causes, such as stress or dehydration. Option D, a history of rheumatic fever, relates to cardiac valvular disease, not hematologic disorders, and does not contribute to the diagnosis of anemia. Moving forward to an insightful perspective, Stancoast Clinical Insight. Clients who report feeling unusually cold, tired, or lightheaded are often demonstrating early signs of decreased oxygen delivery rather than reacting to environmental temperature. It is essential for nurses to correlate these subtle cues with laboratory results when evaluating for anemia. Finally, turning to a high-yield exam takeaway, Stancoast High-Yield NCLEX Pearl. Remember this easy chain: low iron, low hemoglobin, low oxygen, low heat production. Cold intolerance in anemia reflects impaired thermoregulation due to decreased oxygen-dependent metabolism. Always assess for inadequate dietary iron intake, chronic blood loss, or gastrointestinal bleeding when a client presents with this symptom. Before we move on, I want to quickly share something that could really help you. You can now join our online NCLEX crash course, specially designed to help you pass the NCLEX on your very first try. This program has already helped over 1 lakh nursing students clear the exam successfully. And now, it's your turn. And here's the exciting part. We're giving a limited time 70% discount on the course fee. But remember, this offer is only for a short period, and seats are filling up fast, so don't wait too long. To enroll, just download our mobile app. You'll find the link in the description box below, or you can scan the QR code you see on your screen. This NCLEX crash course is truly a one-stop solution. It's a proven shortcut that helps you study smart and pass with confidence. So don't wait. Enroll now and stay ahead of thousands of other students in the race to pass the NCLEX. And yes, if you'd like some free PDF notes for NCLEX questions and a free NCLEX ebook, just download the mobile app. You'll get instant access to all those materials right away. All right, let's get back to learning. Here comes the next question. Let us continue with another insightful case that beautifully connects nutrition, hematology, and clinical reasoning. During a detailed dietary assessment, a nurse discovers that an adult client has been intentionally skipping meals for several months and has recently eliminated certain food groups from their diet. Laboratory results reveal low hemoglobin, low hematocrit, and the presence of microcytic hypochromic red blood cells, classic indicators of iron deficiency anemia. Based on this assessment data, the question asks which dietary omission most likely contributed to the client's condition. Here are the options to consider. Option A is milk, Option B is meat, Option C is fruits, and Option D is vegetables. The correct answer is Option B, meat. Iron-deficiency anemia occurs when the intake or absorption of iron fails to meet the body's ongoing demand for red blood cell production. Among all dietary sources, heme iron, present in animal-based foods such as red meat, poultry, and fish, is the most efficiently absorbed form. It is absorbed through a specialized duodenal mechanism that is minimally influenced by other dietary elements. In contrast, plant-based foods such as legumes, grains, and leafy greens contain non-heme iron, which has lower bioavailability and is affected by inhibitors like phytates and oxalates. Therefore, when a person eliminates meat from their diet, whether due to fasting, personal choice, or restrictive eating, the major source of heme iron is lost. Over time, this results in depleted ferritin stores, impaired hemoglobin synthesis, and the development of microcytic, hypochromic red blood cells that are small and pale. Clinically, this presents as fatigue, pallor, cold intolerance, dizziness, and sometimes pica. An unusual craving for non-food substances like ice or clay. Although milk is high in calcium and protein, it contributes little to iron intake and can even inhibit iron absorption when consumed excessively. Fruits, while valuable for vitamins and antioxidants, provide minimal iron but can enhance non-heme iron absorption when paired with vitamin C-rich varieties like citrus or berries. Vegetables do contain some iron, but it is primarily in the non-heme form and less efficiently absorbed. Therefore, among all these options, omitting meat creates the most significant and sustained reduction in iron availability, directly causing iron-deficiency anemia. Transitioning to a deeper insight into clinical reasoning, Stan Coast. Clinical insight: not all iron is created equal. Heme iron from animal foods is absorbed 2 to 3 times more efficiently than non-heme iron from plant sources. Always evaluate dietary heme iron intake before labeling anemia as purely nutritional or pathological. And now moving into the Stan Coast high-yield NCLEX Pearl: low meat intake, low heme iron, low ferritin, microcytic, hypochromic anemia. Encourage clients who avoid meat to combine plant-based iron sources like spinach and lentils with vitamin C-rich foods such as oranges or strawberries to maximize absorption and prevent anemia. Moving forward into this next scenario, let us focus on a vital area of pharmacological nursing education: iron supplementation and its absorption principles. A nurse is providing medication education to a client who has been newly prescribed ferrous sulfate, also known as Thiosol, 10 milligrams orally, once daily for the treatment of iron-deficiency anemia. The nurse must instruct the client on the best time to take the medication for maximum absorption. Here are the options. Option 1, 2 hours after a meal. Option 2, with any meal of choice. Option 3, just before eating a meal. And Option 4, at bedtime with a snack. The correct answer is Option 1, 2 hours after a meal. Iron absorption within the gastrointestinal tract is highly sensitive to timing, stomach acidity, and dietary interactions. Ferrous sulfate provides ferrous iron, which is the most efficiently absorbed form in humans, and its absorption occurs primarily in the duodenum and upper jejunum. For optimal uptake, it should be taken on an empty stomach with a full glass of water, ideally 1 hour before or 2 hours after meals, when gastric acidity is highest. Taking the medication with food, especially foods containing phytates like grains, oxalates from spinach or tea, or calcium-rich dairy, can reduce iron bioavailability by more than half. Similarly, medications such as antacids, proton pump inhibitors, or tetracyclines interfere by either increasing gastric pH or forming insoluble complexes with iron, making it unavailable for absorption. Therefore, to achieve therapeutic efficacy, the nurse should emphasize timing and avoidance of these inhibitors. If the client experiences gastrointestinal discomfort, such as nausea or constipation, the nurse can recommend taking ferrous sulfate with a small snack as a compromise. However, this should be a secondary option since it lessens absorption. Taking it just before eating, Option 3, allows it to mix with food, while taking it with meals, Option 2, or at bedtime with a snack, Option 4, not only impairs absorption, but can also increase gastrointestinal irritation when lying down. To further enhance absorption, clients should be encouraged to take iron with a source of ascorbic acid, such as orange juice, since vitamin C converts ferric to ferrous iron and boosts intestinal uptake. Nurses should also provide anticipatory guidance about common side effects, such as black stools and constipation, and explain that these are expected and harmless. Importantly, clients must continue therapy for several months after hemoglobin normalization to rebuild iron stores and prevent relapse. Transitioning to the stand coast, clinical insight. Remember, an empty stomach equals better absorption, but patient comfort matters. If discomfort arises, use a small snack rather than skipping doses. Always avoid pairing iron with milk, caffeine, or antacids to ensure proper uptake. Moving forward with the Stand Coast High Yield NCLEX. Pearl, iron supplements absorb best 1 hour before or 2 hours after meals in an acidic environment. Vitamin C enhances absorption, while calcium, dairy, and tea inhibit it. Always educate clients that dark stools and mild constipation are expected, and that treatment must continue for 3 to 6 months after hemoglobin recovery to restore ferritin reserves completely. Let us smoothly transition into an essential pharmacology-based NCLEX scenario that focuses on patient education and absorption principles. A nurse is educating a client who has been newly diagnosed with iron-deficiency anemia about how to maximize the absorption of an oral ferrous sulfate supplement. The nurse should instruct the client to take the iron tablet with which beverage for optimal absorption. The options are as follows. Option 1, milk. Option 2, tea. Option 3, soft drink. And option 4, orange juice. The correct answer is option 4, orange juice. Now, let us explore the advanced rationale in depth. Iron absorption primarily occurs in the duodenum and upper jejunum, and this process is highly dependent on stomach acidity and the chemical form of iron. The body absorbs ferrous iron, Fe2+, most efficiently, whereas ferric iron, Fe3+, is poorly absorbed. Vitamin C, also known as ascorbic acid, plays a critical role by acting as a reducing agent. It converts ferric iron to ferrous iron and maintains it in a soluble state even in the alkaline environment of the small intestine. This is why pairing iron supplements with vitamin C-rich beverages like orange juice significantly enhances gastrointestinal absorption and supports effective erythropoiesis, or red blood cell production. In contrast, milk should be avoided because it contains calcium and casein, both of which bind to iron and form insoluble compounds that hinder absorption. Similarly, tea contains tannins and polyphenols that chelate iron, further reducing its bioavailability. Soft drinks, especially those containing caffeine or phosphates, can alter gastric pH and decrease the acidic environment needed for proper iron absorption, offering no nutritional benefit. Transitioning to a clinical insight from Stand Coast, remember this golden rule. Acid unlocks iron's potential. Pairing iron with vitamin C ensures maximum absorption, never with milk, tea, or antacids. An acidic stomach equals better uptake. Moving forward to the Stand Coast High-Yield NCLEX Pearl, iron supplements are best taken on an empty stomach, ideally 1 hour before or 2 hours after meals. Accompanied by a vitamin C-rich drink such as orange juice, students should remember to avoid taking iron with calcium, caffeine, or high-fiber foods, as these can interfere with absorption. Finally, iron therapy should be continued for 3 to 6 months after the correction of anemia to rebuild ferritin stores and prevent recurrence of deficiency. Let us now transition into another insightful question centered around pharmacologic education and patient understanding. When the nurse is educating a client prescribed oral ferrous sulfate therapy for iron-deficiency anemia, which statement made by the client reflects an accurate understanding of one of the expected side effects of this medication? The options presented are as follows. Option 1 says, "My stool will remain medium brown." Option 2 states, "My stool may turn dark black or greenish in color." Option 3 mentions, "My stool will become clay-colored." And option 4 notes, "My stool might appear light green." The correct answer is option 2, "My stool may turn dark black or greenish in color." Now, diving into the expanded rationale, when clients start taking iron supplements such as ferrous sulfate or ferrous fumarate, one of the most common and harmless effects they notice is a change in stool color. The stool often appears dark black or greenish because unabsorbed iron gets excreted through the gastrointestinal tract, and when it oxidizes in the colon, it turns the stool dark. It is important for nurses to reassure clients that this color change is completely normal and does not indicate gastrointestinal bleeding. Iron absorption primarily takes place in the duodenum and upper jejunum, and the body absorbs the ferrous, Fe2+, more effectively than the ferric, Fe3+ form. Vitamin C plays a key role by maintaining iron in its ferrous state and increasing its solubility, thereby improving absorption. However, the portion that remains unabsorbed becomes oxidized, leading to the dark stool color. By contrast, a normal stool color is medium brown due to bilirubin metabolism, while clay-colored stool usually signals an absence of bile pigment, as seen in biliary obstruction or liver disease. Light green stool may appear with rapid intestinal transit during diarrhea or after consuming certain foods or dyes, but it is unrelated to iron use. From a nursing education perspective, it is vital to counsel clients not to stop taking iron supplements due to stool discoloration. Instead, they should increase water and dietary fiber intake to counteract constipation, which is another common side effect of iron therapy. Clients should also be taught to take the medication on an empty stomach with orange juice or any vitamin C-rich drink to improve absorption, and to avoid taking it with milk, tea, or antacids, as these inhibit absorption. Now shifting toward a professional reflection, Stancoast Clinical Insight, dark stools during iron therapy are a sign of compliance, not a complication. Nurses must always distinguish this harmless color change from true melena by checking stool texture, odor, and associated symptoms. And building upon that wisdom, Stancoast High Yield NCLEX Pearl. When teaching clients about iron therapy, always highlight that black or greenish stools are expected, constipation is common, and iron should ideally be taken on an empty stomach with a vitamin C-rich beverage. Calcium, caffeine, and high-fiber foods can interfere with absorption. Encourage clients to continue therapy for 3 to 6 months after hemoglobin normalizes to replenish ferritin stores and prevent relapse. Moving on to our next clinical teaching point, let us explore a scenario focused on medication safety and patient education. A client diagnosed with iron-deficiency anemia contacts the clinic 3 days after starting ferrous sulfate therapy, reporting difficulty swallowing the large iron capsule. The healthcare provider then prescribes a liquid iron preparation instead. The nurse must now reinforce essential teaching points to ensure safe and effective administration. The question asks, when providing education about this new medication form, which instruction should the nurse emphasize to ensure proper administration and minimize complications? Here are the options. Option 1 says, use a straw when taking the liquid iron. Option 2 advises, drink the liquid iron from a paper cup. Option 3 suggests, pour the liquid iron over crushed ice. And option 4 mentions, mix the liquid iron with whole milk. The correct answer is option 1, use a straw when taking the liquid iron. Now, let us carefully discuss the expanded advanced rationale. Liquid iron preparations, such as ferrous sulfate elixirs, are highly effective for clients who cannot swallow capsules. However, they carry the significant drawback of staining teeth if administered improperly. Therefore, the nurse should instruct the client to sip the medication through a straw, preventing direct contact between the iron solution and the enamel. This technique minimizes discoloration and protects dental appearance. Additionally, the nurse should teach the client to dilute the solution with at least 2 to 4 ounces of water or a vitamin C-rich juice, such as orange juice. This not only improves taste, but also enhances absorption, since vitamin C converts ferric iron into its ferrous form, the most absorbable state within the duodenum and proximal jejunum. Following ingestion, the client should rinse the mouth or brush the teeth to remove residual iron particles that might contribute to enamel staining. Shifting focus to the incorrect options, option 2, drink the liquid iron from a paper cup, does not protect teeth and might even interact with certain coatings used in disposable cups. Option 3, pour the liquid iron over crushed ice, changes the temperature and taste but provides no benefit for preventing discoloration or improving absorption. In fact, cold liquids may slow gastric emptying and delay drug dissolution. Finally, option 4, mix the liquid iron with whole milk, is contraindicated because calcium and casein in milk bind to iron and form insoluble complexes, drastically reducing its absorption and therapeutic effect. Iron should also never be taken with antacids, bran, tea, or coffee, as they similarly hinder absorption. From a nursing standpoint, it is equally important to teach clients that mild gastrointestinal discomfort, constipation, and dark or greenish stools are expected effects, not warning signs of bleeding. The nurse should also emphasize avoiding concurrent use of iron with tetracycline antibiotics or antacids within 2 hours, since these interfere with absorption. Reinforcing these teaching points builds medication adherence and prevents unnecessary anxiety. Transitioning to the stand coast, clinical insight, liquid iron stains enamel, but teaching clients to sip through a straw and rinse immediately after. Dosing protects both teeth and therapeutic compliance. Small technique, big impact. Moving forward with the stand coast high-yield NCLEX Pearl. For maximum absorption, always pair iron with vitamin C-rich fluids, never with milk or antacids. Teach clients that dark stools are expected, and iron therapy must continue for 3 to 6 months after recovery to rebuild ferritin stores and prevent relapse. Let us now move into another critical clinical reasoning scenario designed for your NCLEX preparation. A 42-year-old client visits the outpatient clinic after recent laboratory findings indicate anemia of unknown origin. During the initial nursing interview, the nurse collects further health history to determine potential contributing factors. The question asks, which piece of information shared by the client would most likely be directly associated with the development of this anemia? Here are the options. Option 1 says, I fainted last week at work. Option 2 mentions, I often have mild headaches. Option 3 explains, I had my gallbladder removed a few years ago. Option 4 states, my abdomen feels slightly tender. The correct answer is Option 1. I fainted last week at work. Now, let us carefully explore the advanced rationale behind this choice. Anemia refers to a reduction in red blood cell count, hemoglobin concentration, or hematocrit, ultimately leading to decreased oxygen carrying capacity of the blood. The symptoms of anemia primarily arise from tissue hypoxia, meaning that body tissues are not receiving enough oxygen. The client's report of fainting or syncope is the most direct sign related to anemia because it results from reduced oxygen delivery to the brain. When hemoglobin levels drop significantly, cerebral perfusion becomes inadequate, especially during physical exertion or positional changes, leading to dizziness, lightheadedness, or even loss of consciousness. This finding is a key red flag indicating the body's inability to meet oxygen demands due to insufficient red blood cell mass or hemoglobin. In contrast, mild headaches are nonspecific and may occur due to dehydration, stress, or tension rather than anemia itself. While certain types of anemia, such as pernicious anemia, can produce neurologic symptoms from vitamin B12 deficiency, simple occasional headaches do not reliably indicate anemia. A prior gallbladder removal, or cholecystectomy, bears no physiological link to anemia because bile secretion plays no role in red blood cell production or hemoglobin synthesis. Likewise, mild abdominal tenderness could suggest gastrointestinal irritation, organ inflammation, or other causes, but is not typically associated with anemia unless there is internal bleeding or abdominal pathology contributing to blood loss. From a pathophysiologic standpoint, fainting in this client signals that oxygen delivery has fallen below cerebral requirements. In response, the body increases heart rate and respiratory rate in an attempt to enhance oxygen transport. But when compensation fails, temporary loss of consciousness occurs due to cerebral hypoxia. Therefore, this symptom serves as an important clinical clue that requires immediate evaluation for low hemoglobin, occult blood loss, or impaired erythropoiesis. Transitioning to the stand coast. Clinical insight. Never dismiss a fainting episode in a client with suspected anemia. It is not just a simple passing out. It represents a physiological warning that the brain is deprived of oxygen. Prompt recognition and assessment can prevent injury and guide investigation toward hidden bleeding, hemolysis, or bone marrow suppression. Moving forward with the stand coast high-yield NCLEX Pearl. Anemia causes reduced oxygen delivery to tissues, producing hallmark symptoms such as fatigue, pallor, tachycardia, dyspnea, and syncope. After any fainting episode, ensure client safety, assess hemoglobin and hematocrit levels, and determine the underlying cause, whether from blood loss, nutritional deficiency, or chronic disease. Before we move on, I want to quickly share something that could really help you. You can now join our online NCLEX crash course, specially designed to help you pass the NCLEX on your very first try. This program has already helped over 1 lakh nursing students clear the exam successfully. And now, it's your turn. And here's the exciting part. We're giving a limited time 70% discount on the course fee. But remember, this offer is only for a short period, and seats are filling up fast, so don't wait too long. To enroll, just download our mobile app. You'll find the link in the description box below, or you can scan the QR code you see on your screen. This NCLEX crash course is truly a one-stop solution. It's a proven shortcut that helps you study smart and pass with confidence. So don't wait. Enroll now and stay ahead of thousands of other students in the race to pass the NCLEX. And yes, if you'd like some free PDF notes for NCLEX questions and a free NCLEX ebook, just download the mobile app. You'll get instant access to all those materials right away. All right, let's get back to learning. Here comes the next question. Let us smoothly transition into this insightful NCLEX-style question that highlights a fundamental aspect of physical assessment. A nurse is performing a comprehensive physical examination on a client who has recently been diagnosed with anemia. During the inspection phase, the nurse must determine which skin finding is most accurately expected in such a client. The options presented are as follows. Option 1 states that the skin appears mottled. Option 2 mentions that the skin is flushed. Option 3 indicates that the skin is pale. Option 4 describes that the skin has a blue tinge. The correct answer is Option 3. The skin is pale. When we look deeper into this rationale, pallor stands out as one of the earliest and most consistent clinical indicators of anemia. This happens because anemia reduces the overall hemoglobin concentration, or red blood cell count, leading to a decline in oxygen-carrying capacity. Hemoglobin normally gives skin and mucous membranes their healthy pink tone by reflecting oxygenated blood through dermal capillaries. However, when hemoglobin levels drop, less oxygenated blood reaches the skin surface, producing a pale or waxy appearance. This pallor is especially visible in highly vascular areas, such as the conjunctiva, nail beds, palms, and oral mucosa. Additionally, compensatory vasoconstriction redirects the remaining oxygenated blood toward vital organs like the heart and brain, further contributing to the visible pallor. In clients with iron-deficiency anemia or acute blood loss, this pallor becomes even more evident due to microcytic and hypochromic red blood cells that cannot efficiently deliver oxygen. The nurse should correlate pallor with accompanying symptoms such as fatigue, exertional dyspnea, or cold intolerance, all of which are classic indicators of tissue hypoxia. Evaluating pallor provides an early visual cue that should prompt laboratory assessments, including hemoglobin, hematocrit, and mean corpuscular volume, to confirm the diagnosis and determine severity. Now, let us analyze why the other options are not correct. Option 1, mottled skin, or livedo reticularis, indicates irregular perfusion or impaired microcirculation and is typically associated with shock, hypothermia, or neonatal temperature instability, not anemia. Moving on to option 2, flushed skin occurs due to vasodilation and increased cutaneous blood flow, which is common in conditions like fever, hypertension, alcohol consumption, or polycythemia vera, where blood is actually hyperoxygenated rather than deficient. Lastly, option 4, a blue-tinged skin or cyanosis, develops from increased deoxygenated hemoglobin and indicates respiratory or circulatory failure. However, in anemia, the total hemoglobin is too low to produce the blue hue, even in hypoxic states. Transitioning to the deeper clinical takeaway, here is the Stan Coast clinical insight. Pallor in anemia is not just a color change, it is a visible reflection of reduced tissue oxygenation. Detecting subtle pallor in the nail beds or conjunctiva allows the nurse to recognize anemia early and prevent complications from progressive hypoxia. And finally, here comes the Stan Coast high-yield NCLEX Pearl. Anemia leads to decreased hemoglobin, which directly reduces oxygen delivery, manifesting as pallor and fatigue. Always assess nail beds and mucous membranes first, as these reveal anemia long before the client experiences overt weakness or syncope. Let us transition into this engaging clinical reasoning scenario that explores a fundamental concept in hematology. A 50-year-old client is admitted for evaluation of fatigue, pallor, and tingling sensations in the hands and feet. The healthcare provider suspects pernicious anemia and requests diagnostic testing. During the admission history, the nurse must determine which question will yield the most relevant information to support the suspected diagnosis. The options are presented as follows. Option 1 asks, "Was all or a portion of your stomach removed?" Option 2 inquires, "Have you ever had any type of hepatitis?" Option 3 asks, "Were you ever informed of other forms of anemia?" And option 4 questions, "Do you have severe allergic reactions?" The correct answer is option 1, "Was all or a portion of your stomach removed?" Now, let us carefully explore the rationale behind this selection. Pernicious anemia is a type of megaloblastic anemia that develops when the body fails to absorb vitamin B12 due to the absence of intrinsic factor, a glycoprotein secreted by the parietal cells of the stomach. This intrinsic factor is vital because it binds to dietary vitamin B12, protecting it from gastric acid destruction and ensuring its absorption in the terminal ileum. When the parietal cells are destroyed, such as in chronic atrophic gastritis, autoimmune disorders, or following gastric surgeries like partial or total gastrectomy, intrinsic factor production is lost. As a result, vitamin B12 cannot be absorbed, leading to impaired DNA synthesis and the formation of large, immature red blood cells called macrocytes. Over time, this causes not only anemia, but also neurological complications such as peripheral neuropathy, ataxia, and cognitive changes. Therefore, asking whether the client has had gastric surgery is crucial, as removal or destruction of parietal cells during procedures like gastrectomy directly causes intrinsic factor deficiency. Clients who have undergone such surgeries often require lifelong parenteral vitamin B12 replacement to prevent irreversible nerve damage. In contrast, asking about a history of hepatitis, as in option 2, is unrelated to the mechanism of pernicious anemia. Although liver disease can affect folate storage and utilization, it does not interfere with intrinsic factor or vitamin B12 absorption. Similarly, option 3, inquiring about other forms of anemia, may provide general background information, but does not directly identify the underlying etiology. Lastly, option 4, which involves allergic reactions, is not relevant, since pernicious anemia results from autoimmune destruction or post-surgical changes rather than hypersensitivity. Transitioning into our Stan Coast clinical insight. Pernicious anemia is not simply about poor dietary intake. It is primarily a problem of absorption failure due to the loss of intrinsic factor. Always connect vitamin B12 deficiency with either autoimmune destruction of gastric parietal cells or surgical removal of the stomach. Moving forward to our Stan Coast high-yield NCLEX Pearl. When you encounter a question describing macrocytic anemia, accompanied by neurological symptoms, think of pernicious anemia first. Always ask about a history of gastric surgeries or chronic gastritis, because without intrinsic factor, vitamin B12 absorption cannot occur, leading to potentially irreversible neurologic damage if not treated promptly. Let us smoothly transition into this insightful question that evaluates your understanding of professional nursing documentation and its boundaries. During the initial nursing interview, the nurse collects both subjective and objective data to build a baseline assessment. The question asks which of the following entries is least pertinent for the nurse to include in the documentation of this assessment. Here are the options to consider carefully. Option 1 states, client states, I get nauseated when I eat. Option 2 reads, the client is currently uninsured. Option 3 notes, the skin over the back and buttocks is flushed. And option 4 includes, the client has asked to see a minister. The correct answer is option 2. The client is currently uninsured. Now, let us thoughtfully explore the advanced rationale behind this selection. In professional nursing documentation, the focus must remain on subjective and objective data that directly influence nursing care, interventions, and client outcomes. The purpose is to maintain clarity, promote continuity of care, and uphold the legal and ethical standards of nursing records. Option 2, which refers to the client's insurance status, is administrative information typically obtained by the admission or business office staff. It does not contribute to clinical decision-making or client care planning. Including such non-clinical data may clutter the nursing record and dilute its professional focus. On the other hand, option 1, client states, I get nauseated when I eat, is subjective data that gives insight into the client's gastrointestinal status and nutritional needs, guiding nursing assessment and interventions. Option 3, the skin over the back and buttocks is flushed, represents objective data, reflecting the nurse's direct observation, which could indicate circulatory changes or the risk of skin breakdown, both clinically relevant for nursing care. Option 4, the client has asked to see a minister, illustrates a psychosocial and spiritual need, which is an integral component of holistic nursing practice, emphasizing care for the whole person, not just the disease. Hence, the least pertinent entry is option 2, as it falls outside the nurse's scope of clinical documentation and belongs to administrative records rather than the nursing care plan. Transitioning to the Stand-Coast Clinical Insight. Effective nursing documentation captures what impacts care, not what belongs to administration. Every entry should reflect assessment, planning, intervention, or evaluation. Nothing less, nothing more. Moving forward to the Stand-Coast High-Yield NCLEX Pearl. When documenting, always think, does this information affect the client's care or nursing decision-making? If not, it does not belong in the nursing notes. Financial status, insurance coverage, or billing details are excluded from nursing documentation, but managed by administrative staff. Moving forward to our next engaging scenario, let us explore a case that beautifully ties hematology with neurology. A client diagnosed with pernicious anemia reports new-onset neurological symptoms, and the nurse must determine which finding is most likely to be described by the client. The options to consider are as follows. Option 1 states numbness and tingling in the extremities. Option 2 lists morning headaches and sudden dizziness. Option 3 notes restlessness and sleep pattern disturbances. Option 4 describes periods of temporary amnesia and fainting. The correct answer is Option 1, numbness and tingling in the extremities. Now, let us dive into the advanced clinical reasoning behind this answer. Pernicious anemia is a type of megaloblastic anemia caused by a deficiency of vitamin B12, most often due to the absence of intrinsic factor, a protein produced by gastric parietal cells necessary for vitamin B12 absorption in the ileum. Beyond producing red blood cells, vitamin B12 is essential for maintaining the integrity of the nervous system. Its deficiency disrupts myelin synthesis, the fatty insulation that protects and facilitates the conduction of nerve impulses along both peripheral nerves and spinal cord tracts. This demyelination results in neurological symptoms such as numbness, tingling in the hands and feet, loss of proprioception, ataxia, and an unsteady gait, collectively termed subacute combined degeneration of the spinal cord. Over time, this condition may progress to spasticity, weakness, or even paralysis if left untreated. Importantly, neurological manifestations often appear gradually and may precede severe anemia. The deficiency of vitamin B12 also interferes with methionine production, a key amino acid for myelin repair, further aggravating nerve injury. In addition to neurological issues, clients may exhibit a smooth, beefy red tongue, glossitis, fatigue, and pallor due to the hematologic component. In contrast, option 2, morning headaches and dizziness, may occur due to general hypoxia in anemia, but are not characteristic of the neurological complications of pernicious anemia. Option 3, restlessness and disturbed sleep, represents more psychological or metabolic disturbances and not neural demyelination. Option 4, temporary amnesia and fainting, may occur from cerebral hypoxia in severe anemia, but are not typical features of vitamin B12 deficiency. Instead, cognitive symptoms like mild memory loss or depression are seen. Thus, the most expected neurological symptom reported by a client with pernicious anemia is numbness and tingling in the extremities, reflecting impaired peripheral nerve conduction caused by demyelination. Before we wrap up, here is your Stand-Coast clinical insight. Pernicious anemia affects more than just red blood cells. It progressively strips nerves of their myelin covering. Early recognition of paresthesia is the nurse's key opportunity to prevent irreversible neurological damage. And now, your Stand-Coast High-Yield NCLEX Pearl. Always connect neurological symptoms in anemia to vitamin B12 deficiency. Folate supplementation may correct anemia, but will not repair nerve damage. Only vitamin B12 therapy can restore neurological integrity. Let us now dive into this fascinating hematology-based diagnostic scenario that blends pathophysiology with clinical interpretation. A client presenting with progressive fatigue, pallor, and numbness in the extremities is suspected of having pernicious anemia. To confirm the diagnosis, the physician orders a Schilling test, and the nurse is preparing to educate the client about this procedure. The question asks which specimen will be collected during the test. The available options are as follows. Option 1 states urine, Option 2 mentions blood, Option 3 indicates stool, and Option 4 specifies sputum. The correct answer is Option 1, urine. Now let us explore the rationale in detail to build a complete understanding. The Schilling test is a specialized diagnostic procedure designed to determine whether a vitamin B12 deficiency results from malabsorption or from a lack of intrinsic factor. which is the defining problem in pernicious anemia. During this test, the client receives an oral dose of radioactive vitamin B12 followed by an intramuscular injection of non-radioactive vitamin B12. This injection saturates the body's storage sites, ensuring that any radioactive vitamin B12, absorbed from the intestine, is excreted through the urine instead of being stored in tissues. The nurse must instruct the client to collect all urine for 24 to 48 hours, which is then analyzed for radioactivity. If the radioactive vitamin B12 level in the urine is low, it means that absorption from the ileum is defective, which is typical of pernicious anemia due to a lack of intrinsic factor secreted by the gastric parietal cells. However, if the urinary radioactivity is normal, the deficiency may be due to other causes such as dietary insufficiency or intestinal malabsorption. Therefore, urine is the key specimen collected in this test because it directly reflects how much of the administered vitamin B12 was absorbed. Blood, stool, and sputum samples have no diagnostic relevance in this context. Blood may be used for complementary studies such as intrinsic factor antibody testing or complete blood counts, but only the urine specimen in the Schilling test provides the quantitative evidence of vitamin B12 absorption. Now moving into the Stand-Coast clinical insight, the Schilling test transforms a biochemical concept into a functional diagnostic approach by measuring how efficiently vitamin B12 is absorbed and excreted. In clients with pernicious anemia, low urinary excretion following radioactive vitamin B12 administration confirms the inability to absorb the vitamin due to intrinsic factor deficiency. Transitioning to the Stand-Coast high-yield NCLEX Pearl. Always associate the Schilling test with radioactive vitamin B12 administration and 24-hour urine collection. Low excretion levels indicate pernicious anemia, emphasizing intrinsic factor deficiency as the underlying cause. As a nurse, educate clients on the importance of proper urine collection, hydration maintenance, and prevention of sample loss for accurate results. Let us move into this next question that connects diagnostic interpretation with lifelong therapeutic management. After confirming the diagnosis of pernicious anemia through a Schilling test, the nurse is educating the client about the long-term management plan for this condition. The client asks, how will this disorder be treated? Here are the options to consider. Option 1 states, the physician will probably prescribe blood transfusions. Option 2 says, the physician will most likely prescribe iron supplement. Option 3 mentions, the physician will probably prescribe vitamin B12 injections. Option 4 indicates, the physician will probably prescribe vitamin K injections. The correct answer is option 3. The physician will probably prescribe vitamin B12 injections. Now, let us understand why this option is correct through a detailed explanation. Pernicious anemia is a type of megaloblastic anemia caused by the body's inability to absorb vitamin B12 from the gastrointestinal tract due to a deficiency of intrinsic factor. This intrinsic factor, produced by gastric parietal cells, binds to vitamin B12 and allows its absorption in the terminal ileum. The Schilling test helps confirm this condition by demonstrating poor absorption of radioactive vitamin B12 that improves only when intrinsic factor is provided. Therefore, since the root cause is malabsorption rather than dietary deficiency, oral supplements are ineffective. The most appropriate treatment is lifelong parenteral administration of vitamin B12, usually given as cyanocobalamin injections. Therapy typically begins with daily or weekly doses until normal blood counts and neurological function are restored, followed by lifelong monthly maintenance injections. This ongoing therapy replenishes body stores, stimulates normal red blood cell formation, reverses neurological symptoms, and prevents irreversible nerve damage. Next, let us clarify why the other options are incorrect. Option 1, which suggests blood transfusions, would be appropriate only for acute blood loss or severe anemia due to hemolysis, not for pernicious anemia. It provides temporary support, but does not correct the vitamin B12 absorption problem. Moving on to option 2, iron supplements are used for iron-deficiency anemia, which results from chronic blood loss or poor dietary intake. Although both iron and vitamin B12 deficiencies can cause anemia, the pathophysiology and treatment differ entirely. Finally, option 4, vitamin K injections, are indicated for bleeding disorders or clients on anticoagulant therapy, as vitamin K supports clotting factor activation, not red blood cell production. Transitioning to our clinical reflection, stand coast. Clinical insight. It is crucial to remember that pernicious anemia is not a problem of intake but of absorption. Hence, oral vitamin B12 therapy will fail without intrinsic factor. Parenteral or intramuscular cyanocobalamin remains the only effective treatment, and adherence to lifelong therapy prevents irreversible neurological complications and ensures hematologic recovery. And to conclude this teaching point, stand coast high-yield NCLEX Pearl. Whenever the NCLEX question mentions that the Schilling test confirms pernicious anemia, immediately associate it with lifelong vitamin B12 injections. Do not be misled by options such as iron therapy, transfusions, or vitamin K. Focus on cyanocobalamin administration and reinforce client teaching about the importance of lifelong compliance and periodic follow-up to maintain stability and prevent relapse. Let us transition into our next advanced NCLEX-style scenario, with a deeper dive into genetics, epidemiology, and nursing implications. A 30-year-old client is admitted to the hospital in the midst of a severe sickle cell crisis. The nurse reviews the client's medical history to identify risk factors and cultural considerations related to the disorder. Based on the epidemiology of sickle cell disease in the United States, the nurse anticipates that this client most likely belongs to which ethnic background? The available options are as follows. Option 1, Mexican American. Option 2, Asian American. Option 3, Native American. And Option 4, African American. The correct answer is Option 4, African American. Now, to understand the reasoning behind this answer, let us explore the advanced rationale in detail. Sickle cell disease, or SCD, is an autosomal recessive genetic disorder resulting from the inheritance of two defective beta-globin alleles, HBS, located on chromosome 11, one from each parent. Individuals who inherit only one abnormal allele have what is called the sickle cell trait. While the trait typically does not cause symptoms, it can be passed on to offspring. However, inheriting two defective genes causes the replacement of normal hemoglobin A with hemoglobin S, fundamentally altering red blood cell structure and function. Under physiological stressors such as hypoxia, dehydration, acidosis, or infection, the abnormal hemoglobin S polymerizes, causing red blood cells to assume a rigid crescent or sickle shape. These sickled cells lose flexibility, clump together, and obstruct microcirculation, leading to vaso-occlusive crises, excruciating pain, ischemia, and potential multi-organ damage. Due to repeated sickling and destruction, the lifespan of red blood cells is drastically reduced from the normal 120 days to just 10 to 20 days, causing chronic anemia and increased bilirubin levels. From an epidemiological perspective, sickle cell disease most commonly affects individuals of African descent. In the United States, approximately 1 in every 10 African Americans carries the sickle cell trait, and 1 in every 365 African American infants is born with the disease. This distribution traces back to sub-Saharan Africa, where carrying a single sickle gene provided a selective survival advantage against Plasmodium falciparum malaria. Over generations, this genetic adaptation persisted and was passed down through descendants who later migrated to the Americas and Europe. Smaller populations with sickle cell disease are also found in Mediterranean, Middle Eastern, and Indian groups due to historical exposure to malaria in those regions. In contrast, Mexican Americans, Asian Americans, and Native Americans have a very low prevalence of the HBS gene, making them statistically less likely to have sickle cell disease. For nurses, understanding this ethnic predisposition is critical, not for stereotyping, but for culturally competent care, early detection, and targeted genetic counseling. In the United States, universal newborn screening programs test for hemoglobinopathies, enabling early initiation of prophylactic penicillin, hydroxyurea therapy, and timely vaccinations to prevent severe infections and improve life expectancy. Transitioning to the Stand Coast clinical insight, in every sickle cell crisis, think beyond managing the pain alone. Focus equally on oxygenation, hydration, and restoring cellular perfusion, because each intervention aims to interrupt the cycle of hypoxia and hemoglobin polymerization that drives the crisis. Moving toward the Stand Coast high-yield NCLEX Pearl. Always link sickle cell disease to African or Mediterranean ancestry and the inheritance of two abnormal HBS genes. Remember, the sickle trait provides malaria resistance, but the disease itself causes chronic anemia, vaso-occlusion, and organ injury, making preventive and supportive nursing care the true cornerstone of management. Wait for a second. If you're aiming to pass on your very next attempt, the ultimate NCLEX crash course is your shortcut, already trusted by more than 100,000 nursing students who cleared their exams successfully. What makes it different? It's an all-in-one package, designed to cover every part of your NCLEX prep, interactive live classes, and easy to watch. Recorded lectures, 5,000 exam-style practice questions, 30 complete practice tests, eBooks, and PDF notes for revision, a ready-to-use student planner, NGN questions broken down in detail. During comprehensive lecture, this isn't just another review, it's everything you need in one. Please scan the QR code right now, or use the link in the description to enroll instantly and grab free content, including PDF notes, practice tests, and NCLEX quizzes. You'll also get. Let us now move into a fascinating hematology-based NCLEX scenario that truly tests your understanding of disease mechanisms and clinical reasoning. During the admission assessment of a client diagnosed with sickle cell anemia, the nurse must determine which clinical findings are directly linked to the pathophysiology of this blood disorder. The options include Option 1, the client's tongue is white; Option 2, the client's urine is cloudy; Option 3, the client is jaundiced; Option 4, the client is nauseated; Option 5, the client has pain; and Option 6, the client is short of breath. The correct answers here are Options 3, 5, and 6, jaundice, pain, and shortness of breath. To understand why these are correct, let us explore the deeper pathophysiological basis. Sickle cell anemia is an autosomal recessive genetic condition resulting from the production of abnormal hemoglobin S. Under conditions of low oxygen, dehydration, or acidosis, the red blood cells change from a flexible biconcave shape into a rigid crescent or sickle shape. These sickled cells are fragile, break apart easily, and have a dramatically shortened lifespan, about 10 to 20 days compared to the normal 120 days. This rapid destruction leads to hemolysis and severe anemia, setting the stage for the classic clinical signs. Beginning with Option 3, jaundice, this symptom arises from the breakdown of sickled red blood cells. As they rupture, bilirubin, a byproduct of hemoglobin breakdown, accumulates in the bloodstream. The liver cannot process this excess bilirubin efficiently, leading to yellow discoloration of the skin and sclera. Therefore, jaundice is a visible and direct indicator of ongoing hemolysis in sickle cell anemia. Moving forward to Option 5, pain, which is one of the hallmark features of this condition. The abnormal sickle-shaped cells tend to clump together, causing blockages in small blood vessels. This obstruction, called vaso-occlusion, prevents oxygenated blood from reaching vital tissues, resulting in ischemia, inflammation, and excruciating pain crises. These painful episodes can occur anywhere in the body, most often in the limbs, back, chest, and abdomen. Pain intensity may range from mild to severe, and repeated crises over time contribute to chronic tissue damage. Next, Option 6, shortness of breath, is another key manifestation. Because the sickled red blood cells carry less oxygen and die prematurely, the body experiences chronic anemia and tissue hypoxia. The reduced oxygen carrying capacity forces the heart and lungs to work harder, leading to symptoms such as dyspnea, fatigue, and tachypnea. This reflects a systemic compensatory mechanism in response to chronic low oxygen delivery to tissues. Now, let us clarify why the other options are not correct. Option 1, a white-coated tongue, usually points toward oral thrush or dehydration, not sickle cell disease. Option 2, cloudy urine, is generally associated with urinary tract infections or dehydration rather than hemoglobinopathy. Option 4, nausea, although it can occur secondary to pain or medications, is not a hallmark feature directly linked to the disease process. Transitioning now to a deeper insight. Stancoast, clinical insight, sickle cell anemia. Manifestations stem from the triad of hemolysis, vaso-occlusion, and chronic anemia. Recognizing the key indicators, jaundice, pain, and shortness of breath, enables nurses to prioritize interventions, prevent complications, and provide targeted, patient-centered care. And to conclude with a high-yield takeaway, Stancoast High-Yield NCLEX. Pearl. When assessing a client with sickle cell anemia, always connect each symptom back to either hemolysis or microvascular occlusion. Pain crises, jaundice, and dyspnea are the red flags that reflect the true underlying pathology, while findings such as white tongue, cloudy urine, or nausea are typically unrelated. Let us now move forward into a critical, high-priority nursing scenario that highlights the importance of quick clinical judgment and evidence-based decision-making. During an acute vaso-occlusive sickle cell crisis, the client reports severe generalized pain, fatigue, and weakness. The nurse observes tachycardia, a mild fever, and an oxygen saturation of 91% on room air. Faced with these findings, the key question arises: which nursing intervention should take precedence at this moment? The available options are as follows. Option 1, improve nutritional intake. Option 2, control severe pain. Option 3, assist with ventilation. And option 4, relieve anxiety. The correct answer is option 2, control severe pain. In a vaso-occlusive or sickle cell crisis, the red blood cells that contain abnormal hemoglobin S become rigid and crescent-shaped when exposed to stressors such as dehydration, infection, or low oxygen levels. These misshapen cells clog the microcirculation, leading to capillary obstruction, tissue ischemia, and intense, deep-seated pain. Among all the interventions, controlling pain takes the highest priority because unrelieved pain activates the sympathetic nervous system, causing vasoconstriction, increased heart rate, and higher oxygen demand. This physiological stress worsens sickling, perpetuating a vicious cycle of ischemia and further cellular hypoxia. Therefore, early and effective pain control not only relieves suffering, but also prevents progression to organ damage. For immediate management, strong opioid analgesics like morphine or hydromorphone should be administered on a continuous or scheduled basis rather than as needed, since the pain is constant and severe. Non-pharmacological measures such as warm compresses, rest, and adequate hydration, either oral or intravenous, further promote circulation and oxygen delivery to affected tissues. Although oxygen therapy, option 3, may become essential if the client develops respiratory distress or the oxygen saturation falls below 92%. It remains a secondary priority because it does not correct the primary cause, vascular occlusion. Similarly, improving nutrition, option 1, and relieving anxiety, option 4, are valuable in long-term care but not in the acute, life-threatening phase of crisis management. Now, transitioning to our stand-coast clinical insight. Before we wrap up this case, let us emphasize a key clinical truth. Pain in a sickle cell crisis is not a mere symptom. It is a clinical signal of tissue ischemia. Timely, adequate, and continuous analgesic administration prevents further sickling, supports tissue recovery, and safeguards organ function. And moving on to the stand-coast high-yield NCLEX Pearl. To conclude this concept, always remember that in a sickle cell crisis, pain management and oxygenation work together to restore balance. But the nurse must first prioritize pain control. Uncontrolled pain exacerbates hypoxia through vasoconstriction and increased metabolic demand. The rule of thumb is simple. Treat pain early, maintain hydration, and closely monitor for life-threatening complications like acute chest syndrome, stroke, or splenic sequestration. Moving ahead to another critical nursing judgment scenario, let us consider the situation carefully. During the nurse's morning assessment, a client with sickle cell disease reports increased knee swelling, tenderness, and warmth. On closer examination, the nurse notes that the affected knee appears edematous, painful, and has limited range of motion. At this point, the nurse must decide which intervention is most appropriate to include in the care plan. The options are as follows. Option 1, help the client to perform passive range of motion exercises. Option 2, assist the client in changing positions to achieve comfort. Option 3, ambulate the client at frequent intervals during the day. And option 4, encourage the client to perform quadriceps setting exercises. The correct answer is option 2. Assist the client in changing positions to achieve comfort. Now let us explore why this option is correct. During a sickle cell crisis, joint pain and swelling, particularly in large joints such as the knees, result from vaso-occlusion, where sickled red blood cells obstruct blood flow and deprive tissues of oxygen. This localized ischemia produces inflammation, edema, and severe pain. The nurse's top priority here is to relieve discomfort while preventing further tissue hypoxia. By helping the client change positions gently and frequently, the nurse reduces joint pressure, promotes local circulation, and prevents complications of immobility like contractures or pressure ulcers. Because every client's pain threshold and circulation differ, repositioning must always be individualized and comfort-based. On the other hand, ambulation and active exercises, including quadriceps setting, are contraindicated during the acute phase of a vaso-occlusive crisis because they increase metabolic oxygen demand and worsen ischemia. Similarly, passive range of motion exercises may aggravate inflammation and intensify the pain in an already swollen joint. Once the acute episode subsides, gentle mobilization can be reintroduced gradually under supervision. During this vulnerable stage, nursing interventions should focus on rest, pain management, hydration, and the application of warmth to encourage vasodilation. Oxygen therapy is often prescribed to minimize further sickling and enhance tissue oxygenation. Within this framework, repositioning becomes an essential component of comfort care. Simple, safe, and entirely patient-centered. Now transitioning to a deeper reflection. Stand coast. Clinical insight. Here is something important to remember. During a sickle cell crisis, movement must be guided by comfort, not by habit or schedule. A nurse's timely repositioning can mean the difference between relief and worsening ischemia. And finally, moving toward the key takeaway, stand coast, high yield, NCLEX Pearl. Before encouraging any form of exercise, always remember the golden rule of a vaso-occlusive episode: rest, reposition, and relieve pain. Only after oxygen delivery and circulation are restored should physical activity be resumed safely. Let us now move to an important clinical judgment question centered around sickle cell crisis management. During an acute sickle cell crisis, a nurse is developing a plan of care for a client who is experiencing generalized pain and fatigue. The client's vital signs reveal a temperature of 100.8 degrees Fahrenheit, a pulse of 110 beats per minute, and a blood pressure of 92/56 millimeters of mercury. The extremities are cool to touch, and capillary refill exceeds 3 seconds. Considering these findings, which nursing intervention would be most effective in maintaining adequate tissue perfusion at this time? The available options are as follows. Option 1. Provide the client with a large quantity of oral or intravenous fluids. Option 2. Assist the client with applying thigh-high elastic compression stockings. Option 3. Elevate the client's lower extremities on 2 pillows. And Option 4. Have the client dangle the legs over the side of the bed. The correct answer is Option 1. Provide the client with a large quantity of oral or intravenous fluids. Now, let us explore the clinical reasoning behind this choice. In a sickle cell crisis, the core problem is vaso-occlusion, where the abnormally shaped sickled red blood cells block the microcirculation. This leads to tissue ischemia, hypoxia, and severe pain. The most effective initial nursing intervention to improve perfusion is ensuring adequate hydration. Increasing oral or intravenous fluid intake helps reduce blood viscosity, allowing red blood cells to flow more freely through capillaries. This improves circulation, enhances oxygen delivery, reduces further sickling, and promotes renal clearance of waste and bilirubin generated during hemolysis. Adequate hydration also helps prevent recurrent sickling by maintaining sufficient plasma volume and preventing circulatory stasis. Hypotonic intravenous fluids, such as 0.45% sodium chloride, are particularly useful because they promote intracellular hydration. In contrast, isotonic or hypertonic solutions may aggravate dehydration. Throughout therapy, nurses must closely monitor intake and output, assess for fluid overload, especially in clients with renal compromise, and encourage an oral fluid intake of at least 3 to 4 liters per day if tolerated. Now looking at why the other options are incorrect. Option 2, using thigh-high compression stockings, focuses on venous return but does not improve oxygen delivery or capillary perfusion. It may actually worsen ischemia by increasing external pressure on compromised areas. Option 3, elevating the lower extremities, primarily assists with venous drainage but fails to enhance oxygen transport in microvascular obstruction. In sickle cell crisis, capillary clumping and microemboli are the main issue, and elevation offers no correction. Lastly, Option 4, dangling the legs over the bed, decreases venous return and encourages pooling of blood, further reducing oxygen delivery to already hypoxic tissues. Therefore, the most therapeutic action remains to optimize intravascular volume and oxygen transport through aggressive hydration, adequate pain management, and supplemental oxygen as indicated. Transitioning now to our Stand Coast clinical insight, think of hydration as the lifeline in sickle cell crisis. Each drop dilutes the thickness of the blood, freeing trapped red cells and reviving oxygen flow to starved tissues. And now for the Stand Coast high-yield NCLEX Pearl. During a vaso-occlusive crisis, always prioritize hydration, oxygenation, and pain relief. These three interventions work together to break the sickling cycle and protect organ function. Fluids restore perfusion, oxygen halts further sickling, and analgesia reduces metabolic demand and stress. Let us now transition into an insightful discussion that connects directly to crisis prevention in sickle cell anemia. In this scenario, a nurse is providing genetic and lifestyle counseling to a client diagnosed with sickle cell anemia. During the session, the client curiously asks, "What kinds of things can trigger another sickle cell crisis?" The question requires the nurse to identify which factors are known to precipitate a vaso-occlusive crisis. The options include low blood glucose level, fatigue, overexertion, overhydration, fever, and smoking. The correct answers are overexertion, fever, and smoking. To understand this clearly, let us unpack the reasoning step by step. A vaso-occlusive or sickle cell crisis develops when red blood cells become abnormally shaped, sticky, and rigid, blocking blood flow and depriving tissues of oxygen. This crisis is typically set off by anything that increases oxygen demand, decreases oxygen supply, or alters blood viscosity. Starting with option 3, overexertion. This is correct because excessive physical activity raises the body's oxygen and metabolic demands, which in turn increases the risk of hypoxemia and acidosis. In clients with sickle cell anemia, this metabolic strain leads to red blood cell sickling and vessel blockage. Even seemingly mild exertion, such as working out in hot or humid weather, can initiate a vaso-occlusive episode. Hence, nurses must educate clients to balance rest with activity and avoid strenuous exertion. Next, let us look at option 5, fever, which is also correct. Fever usually signals infection or inflammation, both of which accelerate the sickling process. Infections elevate metabolic rate, reduce available oxygen, and cause dehydration through fluid loss. Moreover, inflammatory mediators alter vessel tone and increase blood viscosity, further impairing circulation. Therefore, nurses must highlight preventive measures, such as timely vaccination, early medical consultation during fever, and consistent hydration. Moving to option 6, smoking. This is another correct trigger. Cigarette smoke contains carbon monoxide and nicotine, both of which are harmful to oxygen transport and vascular health. Carbon monoxide binds to hemoglobin, forming carboxyhemoglobin, which drastically reduces oxygen availability to tissues. Nicotine, on the other hand, causes vasoconstriction, limiting microcirculatory flow. Together, these effects make smoking a major modifiable risk factor for triggering crises. Now, let us briefly review the incorrect responses. Option 1, low blood glucose level, does not directly influence oxygen delivery or sickling of red cells. Although it may lead to fatigue or weakness, it is unrelated to the pathophysiology of a crisis. Option 2, fatigue is a symptom that follows a crisis due to anemia and tissue hypoxia, but does not independently trigger one. Finally, option 4, overhydration is actually protective. Maintaining adequate hydration decreases blood viscosity and helps red cells flow more smoothly through vessels. Now shifting toward a professional reflection, Stand Coast clinical insight. At the heart of every sickle cell crisis lies one common event: impaired oxygen delivery. Anything that heightens oxygen demand, reduces oxygen supply, or thickens the blood is a critical warning sign nurses must recognize early to prevent crisis development. And building upon that wisdom, Stand Coast high-yield NCLEX Pearl. Remember the easy-to-recall trio: fever, fatigue from overexertion, and fumes from smoking. These are the 3 classic triggers of a vaso-occlusive crisis. Prevention relies on adequate rest, consistent hydration, warmth, and prompt infection control. The ultimate defense against red cell sickling. Moving ahead into another insightful clinical scenario, let us explore a question that beautifully tests your grasp of genetic inheritance and nursing education. A client has recently discovered that both of their parents carry the sickle cell trait and is now worried about what it means for their own health. The client asks the nurse, "What does having the sickle cell trait actually mean for me?" Now, let us look carefully at the options. Option 1 states that people with sickle cell trait eventually develop sickle cell disease in adulthood. Option 2 suggests that individuals with the trait experience a milder form of the disease during stressful conditions. Option 3 mentions that people with sickle cell trait usually remain asymptomatic because they carry one normal and one abnormal hemoglobin gene. And Option 4 claims that individuals with the trait have a significantly shortened lifespan and frequent vaso-occlusive episodes. The correct answer is Option 3. People with sickle cell trait usually remain asymptomatic because they carry one normal and one abnormal hemoglobin gene. To understand this more deeply, let us carefully unpack the science and nursing relevance behind it. People with the sickle cell trait, also called HBAS, inherit one normal hemoglobin A gene from one parent and one abnormal hemoglobin S gene from the other. Because this abnormal gene is recessive, the normal HBA gene prevents the complete expression of the disease. Therefore, these individuals do not develop sickle cell anemia, but remain carriers, capable of passing the trait to their offspring. In contrast, sickle cell disease, or HBSS, develops when a person inherits two abnormal hemoglobin S genes, resulting in chronic hemolysis, vaso-occlusive crises, and multi-organ complications. Most people with the sickle cell trait lead normal, symptom-free lives and enjoy a normal life expectancy. However, under extreme physiological stress, such as severe dehydration, high altitude, unpressurized air travel, or intense physical exertion, some red blood cells can temporarily sickle, leading to rare complications like hematuria, splenic infarction, or exertional rhabdomyolysis. This knowledge is particularly important for athletes, military recruits, and aircrew members, where screening, hydration, and rest become key preventive measures. From a genetic counseling perspective, when two carriers, HBAS and HBAS, conceive, there is a 25% chance of having a child with sickle cell disease, HBSS, a 50% chance of having a carrier, HBIS, and a 25% chance of a normal child, HBAA. Therefore, client education and preconception counseling are major nursing priorities to help families make informed reproductive choices. Now, let us analyze why the other options are incorrect. Option 1 is inaccurate because individuals with the trait do not develop the disease later in life. Gene expression remains constant. Having one normal gene is enough to prevent the disease. Option 2 is misleading since the sickle cell trait does not represent a milder version of the disease. It only causes transient issues in extreme conditions, not chronic or recurrent crises. Option 4 is also incorrect, as those with the trait have a normal lifespan. Frequent crises and complications belong to people with the disease, not carriers. Transitioning now to the Stan Coast clinical insight, having the sickle cell trait means carrying potential, not pathology. The nurse's responsibility lies in education, genetic counseling, and prevention of rare, stress-induced complications through proper hydration, rest, and awareness. Moving on to the Stan Coast High-Yield NCLEX Pearl. Always remember this genetic formula. Trait equals 1 S gene, disease equals 2 S genes. Educate clients that carriers remain asymptomatic but can transmit the gene to their children. Emphasize preconception counseling and hydration awareness during strenuous physical activity or high-altitude exposure.